So it's an honor for us, Roy, to have you here, and we very much look forward to your new data and to your presentation, which is entitled Thresholds for Metabolic Effects of Excess Liver Fat across the BMI range, and these are data from ReTune and direct trials. So Roy, over to you. I'll just stop sharing.
Thank you, Helena. Here we are. If I start my sharing. So, Helena, thank you very much for that kind introduction. Ladies and gentlemen, I'm really pleased to be able to talk to you today, especially with you looking at what we saw when this meeting was held in Newcastle. Here we are down at the Newcastle quayside, and we were in a building right next to this, which is our Millennium Bridge, which pivots around its axis to raise its deck and let ships pass underneath. And we were very fortunate that, in fact, the bridge did tilt whilst we were having our meeting, and we were able to observe this phenomenon. But I'd like to talk about a different phenomenon, and that is the threshold effect of liver fat. Let me take you back to 2004, when a person came to see me, a doctor came to see me, indignant that they had got type 2 diabetes, and they didn't want treatment. They wanted to know how to get rid of it. Now, at that time, I was aware of Hannah's work on excess liver fat and insulin sensitivity. I was aware that other people were interested in this area. Kit, for instance, who we'll be speaking later, Kit Falk-Peterson. But I knew that excess liver fat caused the insulin resistance, which caused the fasting hyperglycemia. So I said to this doctor, what you need to do is to lose weight, even though your BMI is 24. And this person went away and did that. But to my amazement, not only did the fasting hyperglycemia went away, the postprandial hyperglycemia slowly disappeared too. And I can tell you, 17.5 years later, this person still has no diabetes. What had happened was excess liver fat appeared to be causing the excess export of fat from the liver. This causes silting up in all sorts of ectopic sites if the subcutaneous fat compartment is fairly well filled already. And Roger Unger dramatically demonstrated in the early 1990s that this chronically would cause that beta cell dysfunction. So this was a hypothesis, and the only thing to do with the hypothesis is to try and destroy it. And we did that by the counterpoint study. And we showed that each of these big four processes was in fact present. But more than that, we went on to test the hypothesis itself by bringing about weight loss. I'd calculated that approximately 15 kilograms weight loss would be needed to do this. Now, it was necessary to achieve this rapidly, to carry out the sort of study I wanted to do, and we achieved an average of 15.3 kilograms weight loss. This caused everything to normalize, and glucose control normalized in this group. This was a counterpoint study, and that really has started off the flood of dietary studies for type 2 diabetes aiming at remission ever since. But one study opens up questions. This is counterpoint, but we had only studied people with very short duration type 2 diabetes. So we studied longer duration, up to 23 years, and showed that duration was a critical thing. Beyond 10 years, there's a very small chance of remission. That's why, with these preliminary data in DIRECT, we studied people only in the first 6 years of type 2 diabetes. But counterpoint also showed that when people went back to eating normally, provided they kept their weight steady, and it remained absolutely steady in the study, the diabetes stayed away. Importantly, when we studied people with and without diabetes with equivalent weight loss, we showed that there was excess fat inside the pancreas related to diabetes, a rapidly labile component. and that this went away rapidly, and it only happened in diabetes. Non-diabetics losing weight in the early months showed no change in pancreas fat. That's a critical observation. But this simple head counting study, of course, has captured the headlines because it's a large study. And we showed that an average of 12 kilograms weight loss at 1 year could cause 46% of this primary care population to be in remission. That's really just the background, but I want to take it further. Just consider these people. And I ask you this question: which one or ones have type 2 diabetes? Perhaps it would help if I showed you their BMI. But in fact, none of them have got type 2 diabetes. They all used to have type 2 diabetes. So let me show you the before and after pictures. You might think it looks fairly different, fairly similar, but look at the neck. That's a giveaway. And again, in men, particularly the tummy, here we see a large tummy, a flat tummy, and again, look at the neck difference. So with this weight loss, the diabetes goes away, but here we have a metabolically healthy person, BMI 37, and this man had diabetes at a BMI of less than 30. What's going on? Well, it was quite clear that we were dealing with a personal fat threshold. And because of my clinical observations, I got together with Rory Holman, because the UK prospective diabetes study database contained the absolute perfect data set for this. And we published the personal fat threshold hypothesis, which stated onset of diabetes is determined by subcutaneous fat capacity, and it only happens, diabetes only happens in people with susceptible beta cells. Many people can be fat merry men and never get diabetes. For the hepatologists, most of your patients with NAFLD will not get type 2 diabetes. Their beta cells just don't have the susceptibility. But only a couple of years after that, Steve O'Reilly's group published the proof that subcutaneous fat capacity was genetically determined by 53 genetic loci. Those people with the lowest subcutaneous fat mass had the highest risk of type 2 diabetes, corrected for BMI, etc., of course. And it was determined very clearly by this in a highly important paper in Nature Genetics. So moving from there, we can ask the important question, important for a slice of your patients. If we consider people with a body mass index under 27%, then about 1 in 7 people in the UK at the time of getting their diabetes diagnosed are in this category. They look thin compared with the rest of the population. And in all the studies I've mentioned, we studied people of BMI 27 and above. So how about if we look at normal weight people? And if we measure the big 4, liver fat, liver VLDL1 triglyceride export, the pancreas fat, and beta cell function, of course, with glucose control. Well, we did this. We recruited a group of people with normal or near normal BMI, and were able to show that after weight loss, liver fat went down, this went down, that went down, and beta cell function went up. Moreover, 70% of this group were able to get rid of their diabetes, as evidenced by BMI, HbA1c less than 48 millimole per mole, less than 6.5%, maintained for more than 3 months. In fact, it was maintained for 12 months. So those are the overall results of Retune. But I want to compare, because in the direct study, we looked at people of this BMI range. Here is the liver fat in the people with type 2 diabetes. Here is the liver fat in the non-diabetic control group. Now, in retune, the diabetic group had liver fat that was normal. Oh, you might say, we could just go home and forget the hypothesis. Well, is that right? And of course, the answer is not, because people without diabetes in this BMI range have a liver fat content that is far lower. This is almost 3-fold greater. That is over 2.5-fold greater than the same in the appropriate BMI range. So you see, we need to consider liver fat in terms of BMI for metabolic purposes. Here, I've combined the whole data from direct and retune and organized it into BMI groups. Look what happens to liver fat. In a way, this will surprise no one. But let me just reassure the hepatologists that I'm not trying to rewrite the textbooks. Of course, the people with the the higher BMIs who had the highest liver fat also had the suggestion of liver damage most clearly written. So the usual threshold seems to be appropriate for liver damage. How about the comparison with non-diabetic controls? Let me explain that the non-diabetics were matched with the diabetics for the post-weight loss period. So we don't have any in this category, and this is a very small group. The true value is probably a little lower than that, but we know from other data that liver fat in this BMI category is going to be around here. So there is a gradation between diabetes and non-diabetes at each BMI point, and it doesn't depend upon an absolute level of liver fat for normality, for the metabolic side effects. Let me just reflect on the data set that gave us our current threshold of a normal of 5.5. This was in the Dallas Heart Study group. The average BMI was 30. Half of the group were obese. And this is well known, but we need to tune our eye into the fact that there are more things than just the liver side effects that we consider in this NAFLD study group. So going back to this graph, we can see that there's a possibility of reducing liver fat in each of these, and that's exactly what we did with our weight loss in direct and in retune. And these are the post-weight loss readings, normalizing the liver fat in every BMI band. Not only that, but producing remarkably similar remission across the bands. Let me just point out that in this range, these were people in primary care. Many didn't achieve adequate weight loss, whereas in our tightly controlled studies, a higher proportion did. But nonetheless, the possibility of remission is there with weight loss. So in this short talk, I've been trying to make really a single point. We know that NASH is determined by supranormal liver fat levels, and the cutoff range for normal is entirely reasonable there. But adverse metabolic effects are determined by individual thresholds. That is so important for managing our patients in the clinic. Anyone with type 2 diabetes who doesn't have a genetic cause for that must have more fat inside their body than they can cope with, and the treatment is weight loss. Thank you.
So thank you very much for this very stimulating presentation. Do we have any questions or comments? Let's start with the panel. Paula.
Hi, good afternoon. Hi, Roy. Very interesting presentation. I'm not sure because I came a little bit late into it, but did you assess by gender difference? Is there through the course the capacity of the remission, is there a difference between men and women in terms of the metabolism, and is that affected by aging?
Thank you. So 2 important questions. With regards to gender, no, men and women both respond in the same way, but there are some differences that we saw in the big study in primary care. Although both genders lost weight similarly, women seem to find it more difficult to keep it down for the 2 years of follow-up. So there was a genuine difference there. It seems to be more difficult, for whatever reason, for women to keep the weight down. And so, yes, they found it more difficult to sustain the remission. And with regard to age, no, age is no barrier. Now, in the studies, I haven't had ethical permission to study over the age of 70. But I'm well aware from the huge number of emails I get from people around the world that some people in their 90s have said, I don't want diabetes, and have lost weight and have reversed their condition and are in remission. Now, anyone needs individual advice from their physician. I'm not suggesting this is something everybody should do, but there appears to be no age effect. Importantly, the people who suffer most from type 2 diabetes are younger people who get it in their 20s and 30s with terrible complications. And these people are going to benefit most from it. But paradoxically, in our studies, younger people tend to do rather less well with the weight loss business. So we really need somehow to jack up the motivation or use drugs that will specifically bring about the weight loss, such as the GLP-1 agonists. There's nothing pure about this. I'm laying out the physiology. It's up to doctors to interpret that and use it for the benefit of patients.
Thank you. The first question was regarding age, but I think that was from John Jones, and that's already answered. The next question here from the audience is from Dr. Agata Treltsa-Wozniak. What method did you use to determine the % of liver fat?
We used, excuse me, we used a magnetic resonance method that depends upon the different frequencies of fat and water. This is called the 3-point Dixon method. That at first was a bit controversial because Lydia Skapaniewicz, for instance, used spectroscopy, and indeed we use spectroscopy, but that only measures the concentration in a small volume of liver. We can assess the liver fat in the whole liver by this ingenious technique. So 3-point Dixon magnetic resonance imaging.
Oh, thank you. Maybe I continue there and ask you the question of, I don't know of any diabetologist who measures liver fat in the patients with diabetes. Do you envision that after, when we have the 20th anniversary for this NAFLD study group, that's already happening? Or is there, I mean, the hepatologists say they don't care about fat. I mean, liver fat, they care about everything else happening in the liver. So do you really care about liver fat? And I mean, if you go in your diabetes clinic, would you measure liver fat in somebody? I know you have a wonderful setup where you can do this, but let's pretend for a second that everyone had the possibility to do your Dixon method or something. So would there be any situation where you think it would be clinically indicated to measure liver fat?
And I hope that in the 20th anniversary of this meeting, everyone will be able to afford a tape measure, because measuring waist circumference is really the best surrogate. If a person's waist has increased from the size it was in their early 20s, almost everybody knows this because of trouser size. If their waist has increased, they have more fat than they need to, because it's just one of these hard facts of life. Putting on inches around the waist is only due to fat. It's not due to anything else as we move into middle age and beyond. So yeah. Yes, I would go for the inch tape. There are very few clinical indications for really wanting to know the liver fat concentration.
Yeah, regarding waist circumference, I can't be quiet since I'm chairing this, but it is I think, quite a joke that in the definition of the metabolic syndrome, there is one threshold for waist circumference in men and one in women. And of course, that waist circumference originally was meant to describe fat distribution, which it does fairly poorly. And we should really have, according to Jean-Pierre Desprez from Canada and his studies, we should have normal values for waist circumference, which are dependent on BMI, because that's completely forgotten. I mean, somebody who is very tall and etc. You know, it's not at all. Doesn't really make a lot of sense. But let me, you know, before you even say something, so let's just go so we have time for these questions. Jerry Kolka, is there a difference in the nature of pancreatic fat in those with type 2 diabetes as compared to non-diabetics?
Now, we're moving into an area there where I can be less certain, because we need to be able to look inside the pancreas and inside the living pancreas or recently living pancreas. There's very good data to suggest that what we're looking at as this really rather small incremental difference between someone with diabetes and someone without diabetes, and that difference is the thing that shifts with acute weight loss, to suggest that that relates to the intracytoplasmic fat that is spread throughout endocrine and exocrine cells of the pancreas. And there are good studies showing that, in fact, these two compartments, the endocrine and the exocrine cells, move in parallel with this regard. So there is indirect evidence to suggest, yes, it's a labile cytoplasmic pool, but really this is an area that needs far more concentrated work to prove it. But I'd add just one other thing. We're talking about what the beta cells see. Now, that's partly the local fat and the fatty acids released from it, but partly the continuous load of VLDL triglyceride and total plasma triglyceride, because the chylomicrons have got some of the same apolipoproteins and are going to be hydrolyzed inside close to the islets. So the beta cells are going to see what's coming out of the liver acutely. I think with the pancreas fat, we're measuring something, yes, that's of interest, but it's only part of what the beta cells see. In all our studies, we see that we completely relieve the beta cells of the continuous load from the outside, which is in fact what was being applied in Roger Unger's famous experiments, because he applied fatty acids from the outside of the beta cell. So I've got to be fairly vague in answering questions about the pancreas fat. I think the physiology has been demonstrated. Lots of questions remain.
Okay, great. We have a question, two more questions. Arse Handberg is asking, do you know if duration of obesity is important for liver fat as well? So have you assessed duration of obesity in your study subjects?
No, we haven't looked at that. That really requires population level measurements or large group level measurements to do that. So really important question, Ursa. And it would be nice to see more data on that particular question. I would expect that the duration does matter, the extent of the overweight and the duration, but also there are confounders of physical activity in particular, which has a modest modulating effect. I'm afraid the physical activity lobby shouts rather loudly. The effect size is rather small, but it's real. So there's that, and then there are different dietary aspects which could be important. So these are studies which remain to be done. Okay, thank you. And although we're a little bit over time already, so a question which I think is really important, and that's from Dr. Shahinul Alam. Do you consider keto diet for NAFLD? I would consider any diet that suited the individual. It's very clear from our studies, it doesn't matter what you eat. Our detailed research has been carried out with a relatively high carbohydrate diet, about 60% sugar. No, that's not what you imagine to treat diabetes. Sometimes our volunteers go home, read the packet, and then ring up saying, "Are you sure this was right?" It doesn't matter. It's the quantity that matters. And nutrition has got itself into a terrible fandangle of talking about minute details and forgetting that quantity is the big thing. So a keto diet suits some people, as is very clear from the enormous enthusiasm it evokes in some people. And if it suits them to lose the weight, that's fine. And provided it's not too severe, there are precious few health benefits. So the dietitians who are shouting from the sideline, keto diets are evil. No, that's not right. So diets, we've got to recognize that people eat food, and the food they eat is what reflects their own desires, and that has to be acknowledged. So a keto diet, yes, but it doesn't matter as long as you achieve the weight loss to get yourself back down towards the weight you used to be in your early 20s.